Hello, lovely friend. I am Dr. Mary Barson.
And I'm Dr. Lucy Burns.
We are doctors
and weight management and metabolic health experts.
And this is the Real Health and Weight Loss Podcast.
Hello, lovelies. We are super excited to be bringing you this series in menopause where we're interviewing guests on their expert subject regarding perimenopause, menopause and beyond. As always, any information in this podcast is just considered general advice, and we would urge you to seek medical attention if you have any concerns about your health. If you're interested in exploring the symptoms of menopause or perimenopause, we have a checklist which you can download at our website, rlmedicine.com/checklist, or as always, you can click the link in the show notes. Thanks, lovelies. Enjoy this series. Hello, lovely friend. How are you? This week we're back. We're back with part 2 of a fabulous conversation I'm having with Dr. Sunita Chelva, who, if you haven't listened to last week's episode, maybe run back and listen to that, because this is part 2 of that conversation. Last week we talked about muscular health around the perimenopause and menopause phase and beyond. And today we're really diving into bone health. Sunita, welcome back.
Oh, thank you for having me again. We had a lovely chat.
I know. It was such a good conversation. And I know that initially we were going to pack it all into one, but honestly, there was no way we could do that. So I'm so glad that you could come back for part 2 of the musculoskeletal syndrome of menopause. And last week, as we talked about, was all around the muscles, but today we're talking all around the bones.
That's right. And you can't separate them all out necessarily. And a lot of the things that we've talked about last week will apply to what we're talking about here in terms of bone health. But bones are supremely important. I mean, we don't think about them. We don't think about it. Osteoporosis is one of the most important things as we age. So from menopause onwards, it's defined as the breakdown of the bony matrix of the internal scaffolding of our bone architecture. So it literally means porous bones, osteoporosis. It is a silent disease and it has devastating consequences. Hip fractures result in 20% morbidity in the years after having one.
So what does that, can you just explain what that sentence means for our listeners?
So breaking your hip results in 20% of women will have terrible impacts in their life that involves more time spent in hospital than some cancers, even after having a heart attack.
Wow.
Yet we don't actually focus on preventing fractures. We don't screen for it.
No.
A lot of my patients get confused between osteoporosis and osteoarthritis. So osteoarthritis is wear and tear of our joint surfaces. Now, the loss of our joint surfaces in osteoarthritis is also under hormonal influence and genetic factors, and very common around menopause, but the terms are confusing. Today we're talking about osteoporosis.
Did people used to call it thinning of the bones, which isn't quite the right term either, is it?
Not quite, no. But it sort of describes that sort of loss of the architecture and strength, really, of our bones.
One of the visuals I like to use that is, I think, helpful is that thinking about, you know, when people build a house and they pour a slab of concrete, in that slab is the Rio, I think it's called, that sort of wire reinforcement. I guess that's why it's called Rio. That's the reinforcement, then you pour the concrete around it. So I kind of think that the bone matrix is a bit like the Rio.
It is, or it's a bit like a honeycomb. It's sort of a structure that, there's lots going on inside that bone. Our bones are living tissue like muscles, as we said. They've got special cells, all of which have special processes and
jobs, really.
That's the word I was looking for. They all have special jobs. So there's cells known as osteoblasts, which build up our bone. There's bony cells known as osteoclasts, which break down bone. They're all modulated by osteocytes. And we build bone, Lucy, from early childhood to early adulthood. And then it peaks, our bone density peaks around the age of 30. And it declines steadily from there, particularly precipitously in this perimenopausal era to menopause. And all of the special cells are all under the influence of estrogen, progesterone, testosterone, and they all respond uniquely to each of these. So estrogen really is good at preventing bone breakdown and actually helps create bone formation. And progesterone also helps to regulate skeletal growth. It's really interesting that women who are still having their periods, I learned this in my research for our talk, that women still having periods in their luteal phase, so the second half of their menstrual cycle, when the progesterone's higher, actually tend to form more bone. They build more bone. Fascinating. But obviously when you lose your cycle, you're not doing that anymore. Testosterone's another thing that we haven't really talked about, but that really is important for bone formation as well. But we haven't got a lot of studies on this, but it's in the pipeline, I believe.
Yeah, which, I mean, because that's one of the interesting things is the difference in osteoporosis rates between men and women.
Very. Women, as we hit menopause, we lose around 10% of our body mass in 5 years. 1 in 3 women have had a fracture related to osteoporosis at the age of 50. And 1 in 2, so that means you or me, Lucy, will have a fragility fracture. So that's like we talked about, the hip fracture, the spinal fracture, just from minimal trauma. That's alarming to me. That's terrifying to me. And that's quite young. I mean, given that our average age of living is 85.1 years or something, I think, in Australia, you know, having a fragility fracture is no laughing matter.
No, absolutely. And I think, you know, we've coined this phrase recently called the glory years, which is the bit, you know, the last third of your life. So you've got your first third. I kind of look and go, well, during that first third, you're growing. You're, you know, establishing your identity, you're sorting yourself out. You might start a little bit of reproduction, maybe second, third, you're still potentially reproducing if you're having children or not, but you're working, you're the mum taxi, you're doing all the things.
You're juggling, doing the mum juggle.
Yeah. Then the last third is really when you're kind of meant to be able to reap the rewards of all your hard work, where maybe you still might be working, but you potentially don't have to work quite as much. You've got, you know, maybe more time to holiday, more time to just spend, you know, maybe you've got grandchildren. Yeah, you're traveling, you're catching up with friends, unless, of course, you're spending all your time in hospital getting your hip fractures sorted.
That's right. And I mean, 20 to 30% of people who have a hip fracture die within a year. And for those who actually do survive, there's a lot of pain, there's a lot of disability, there's impact on mental health, and not to mention, you know, DVTs, so clots, urinary tract infections, urosepsis. And there's this cascade effect that we do see with people who have osteoporosis, osteoporotic fractures rather, who if you have one, you're more likely to have another one, and so on and so forth. And that actually applies to women who have, you know, even wrist fractures, so falling over, tripping on a pavement from your height, falling over and breaking your wrist. You're more likely to have other more significant fractures going forward.
Yeah, and I think it's interesting, isn't it, that we almost sort of tolerate wrist fractures as being inevitable. Oh, well, you fell over, so of course you broke your wrist.
Inconvenient, yeah.
Yeah, but people who are 20 fall over and don't break a wrist.
They shouldn't. They shouldn't.
No. So why then would somebody who's 50 break a wrist unless they've got osteoporosis or osteopenia? And in fact, that was one of my questions. If you could explain the difference between osteopenia and osteoporosis?
Yes. So osteopenia is just low bone density or weakened bones. Osteoporosis is actually, by definition, having a minimal trauma fracture. But really these terminologies come about through bone density measurement. So we have this thing known as a DEXA scan. It's a very simple low radiation scan which looks at bone density in sample areas. So in our lumbar spine, in our hip, our femoral neck of our femur or our wrist. It gives a T-score, which is a measurement of bone density compared to other aged matched individuals. So 0 to -1 is considered normal bone density. -1 to -2.5 is classed as osteopenia, low bone density. And greater than -2.5 is classed as osteoporosis. We can't look at someone as a clinician and say, I know what's going on. You've got sometimes we can. They're sort of hunched over.
Yeah.
It's often missed. I have had quite a few women coming into HERA in their 40s with T-scores of -4, so something that you would expect to see in an 80 or 90-year-old. You'd never guess by looking at them they would be, they'd look like the picture of health. And so this is why it's extremely important to consider asking for a DEXA scan from your GP for this reason. Perimenopause, actually, Medicare doesn't cover DEXA scans until a woman is over 70 or has a minimal trauma fracture. So that's those fractures we talked about. Coughing and breaking a rib, tripping over and breaking your wrist. It's too late by then, but in perimenopause, we know it can last quite long, from 4 months to 10 years. Studies have actually shown that there is escalated bone loss through that period as well. It's not just that one day of menopause that suddenly everything goes down. It's bubbling away probably, as we said, from our 30s. And so it makes a case for us to really start screening for this earlier.
Way earlier than 70 by the sounds of things.
And it's not just hormonal, as we said. It's not always just about hormones. Some women we would classify like those women I talked about who've got T-scores of -4. They're very rapid losers of bone, and that's a genetically determined thing. Obviously, aging, reduced physical activity, change in metabolic health, same as muscles, it also impacts. Poor nutrition, if you've been on steroids for a long period of time, if you have an autoimmune or thyroid disease, smoking, drinking, even drinking 2 units of alcohol regularly will impact your bones. A lot of women are on SSRI antidepressants, and they're readily prescribed at this age. A lot of GPs are very reluctant post-WHI to actually prescribe HRT. SSRI antidepressants have shown to have a significant impact on bone density, and it's not often considered at all.
Oh, I didn't know that.
Yeah, which is interesting to think about. The Olympics are on at the moment, Lucy, and a lot of these supreme athletes, the gymnasts, will have quite suppressed hormonal profiles. So a lot of these women, by virtue of over-exercising, perhaps have eating disorders. Some women actually have primary ovarian failure or early menopause, so that's losing all of your hormones younger than the age of 40. That can have a huge impact on where a woman reaches her peak bone density, and these women need to be screened early, particularly.
Yeah. My daughter has celiac disease, and she got screened.
Excellent.
As a 20-year-old, because we have no idea how long she'd had it for. She was one of those asymptomatic people who didn't have any gut symptoms, just had prolonged iron deficiency. Yeah, her gastroenterologist is completely onto it, and she'll have regular screens now. As a GP, I reflect back now on how poorly I understood menopause health and probably the number of women that I dismissed, even though I considered myself pretty patient-centric. so many things I now think about where I go, oh my God, around everything, around, health, metabolic health, now osteoporosis, how many people didn't screen, so many things.
So true. And by virtue of the fact that it wasn't taught, it wasn't talked about, I feel like we've missed out on 20 years of really being preemptive about women's health particularly. It's good that we're talking about it now, but I agree. I shudder when I think about the number of women that I haven't actually looked at through this lens.
Yeah, absolutely. So what would your advice be to say, let's say you're a woman who let's say you're in your 60s and you've just been told that you've got osteopenia. What would you advise them?
Well, it depends, I guess, coming in to see me, whether they I normally would look at the menopause side of things as well. But let's talk about first, what would we do in terms of diet, exercise, and lifestyle modification? Because these are really, really important alongside that. So diet, getting vitamin D, either from sun exposure or from supplementation. I mean, I don't like supplementation for no reason. It has to be guided by a blood test. Depends on the individual need. I mean, someone with darker skin like me, Lucy, is not going to absorb sun as well as you are. Calcium from the diet's really important. We always say from the diet as opposed to supplementing, but nuts and vegetables, dairy, of course, but if you really aren't having those things, then maybe supplementation carefully. Vitamin D and calcium. I mean, a lot of my patients say, I've got osteopenia. It's okay. I'm on vitamin D and calcium. It's okay. But we know, I mean, even from that bad old WHI study, they did show that vitamin D and calcium alone are really not good enough for fracture prevention. So they help with bone maintenance. They're important overall for lots of other reasons, but they're not going to prevent your fractures. Cutting down on alcohol and smoking is really important for bone health. And as we said before, eating protein, eating lots of green leafy veggies, adding to our diets is really, really important. Exercise is superbly important. And once again, heavy resistance and high impact training has been shown to really make a difference. There have been some trials, the Lift More trials in Queensland, which you've probably heard about, which have shown that high impact, high resistance training is very effective in stimulating bone growth, particularly in women who've got osteoporosis and osteopenia. There's a special program called ONeuro, which came out from this study, and you can actually seek out specific exercise physiologists and physios who can help you deliver that, into your everyday practice. As we said before, it's not about bulking up. It's about strengthening what we have. And certainly a specific targeted training regime, starting small, can really make a difference to our bones and can actually improve bone density. We can see that on a DEXA scan. So it's definitely worthwhile doing it. Even if you're jumping off a step 10 times, that's enough impact every day. So if you're playing tennis or playing netball, you're going to be doing it. And starting these practices early, teaching our daughters, teaching our young women, do it from your 20s, do it from even before. It's never too late to start changing, remodeling our bones and our muscles. They're all dynamic tissues. HRT is an extremely effective treatment for osteopenia and osteoporosis. And it is actually, a preventative and a treatment for fractures as well. And it's better than any of the weapons grade medication. One of my colleagues here, an endocrinologist, loves to call all the other medications the weapons grade medications.
Yeah, they're pretty intense, some of them.
Oh, they're very intense. I mean, there's just, quickly, there's bisphosphonates. You may have heard about them. They prevent bone breakdown. There's an injection that you have every 6 months, Prolia. There's all sorts of medications that are out there that, in certain cases will need to be used. But when you stop them, your bone density slides back down again.
And Prolia has, that risk of vertebral fractures if you are late even.
Rebound fractures.
Yeah, which is really scary, and a lot of people are not aware of it.
Not aware of it at all. And, you know, if we're talking about women, so this woman is 60 with osteopenia, she, as we said, might live till 85. You don't really necessarily want to be on these big guns for 20 years. Whereas hormone replacement therapy, if you've got other symptoms, as we said, and we'll say it again, if it means you sleep better, you feel better, you have more energy, you're more likely to go out and address your diet, pay attention to your exercise, optimize those things. The flow and effect on your bones will also come from there. But they themselves, HRT, will treat osteopenia and osteoporosis and prevent that slide further. So very, very useful. The benefits, and nowadays we know that they can be taken for as long as the benefits outweigh the risks. Even for women who have osteopenia, it's likely to be extremely, extremely useful.
Yeah, absolutely. And I think, you know, again, getting back to the glory years, medicine is very good at keeping people alive for a long time now. We're pretty good at that. But there's not many of our medications that really improve the quality of your life or the health span of your life. So things like, you know, MHT again for bone muscle health as a quality of life component, not just for the perimenopause phase but beyond, is really, really important.
Absolutely. Living, I mean, I think a lot of my patients and I have the conversation that you could be taken out by a bus tomorrow. Something could happen. You have to do the best you can with what you have, and you might as well live with quality. Some of my post-breast cancer patients will also have these discussions with, because we live longer, we are going to be having diseases, you know, experiencing cancers, and living with quality and optimizing everything that we can.
Yeah. So, which I guess then brings me to the next point, which is the people that can't take HRT or don't want to take out HRT or for whatever reason, the things that they need to focus then come back to those basics by the sounds of things.
Always.
Yeah.
I think whether you take HRT or not, those basics have to be in place. It's only part of the picture. It's got to be all of it.
You mentioned just doing some jumping. This would be, I reckon, the thing that people don't have any idea about, that jumping, a little jump.
Off a step.
Yeah. And you can, even if that feels a bit scary, you can just start again in the kitchen, holding onto your bench, and just do one little jump and see how you feel.
That's right. There's this fear of injury. I don't know why, but we've always been taught, you know, pain is bad, injury is dangerous, we need to wrap ourselves in cotton wool. Humans are amazing, and we can do amazing things, and we can recover from amazing things, but we don't have to be afraid of doing things. And getting back to that inner child is actually quite enlightening, I think, to allow yourself to be able to do that. I think don't be afraid of the fact that you might pull up a bit sore or you might feel a bit weak, but it will get better. Challenge yourself, I think, is a big message.
I think probably, you know, for lots of people I know around that age, that 60-year-old age, they've got osteoarthritis in their knees. Maybe they've had joint replacements even by now, and they are scared of impact. So, again, you don't need to fear impact. You just need to do it slowly.
Do it slowly and build on that. That's right.
Yeah. Don't go out jumping. You know, don't buy a skipping rope and jump 500 things if you haven't jumped once.
That's right.
Yeah.
That's right. I agree.
So some impact is going to be helpful. We're going to, you know, if anyone's smoking, hopefully you're not doing that by now, reducing alcohol. Any thoughts on coffee?
Well, coffee, poor old contentious coffee is, you know, like for many reasons, I think it needs to be in moderation. The effect of caffeine has been shown to be beneficial for metabolism. I think that excessive amounts may have an effect on bone density, similarly on kidney function, and just needs to be kept in moderation. I think any of our practices, any of our little vices that we covet and we overdo needs to be pared back, because it certainly can have an impact on bone health as far as I'm aware. What are your thoughts?
Yeah, pretty much the same. I think that, unlike, say, smoking, where there is zero benefit of any amount, and honestly, I'd also say alcohol, the alcohol industry have done a great job of convincing us that a small amount of alcohol is helpful to your health. I don't think it's helpful.
I think that notion's gone out the window. Yeah.
Yeah, it's still pretty entrenched in the community that, drinking red wine daily is good for your health. It's not. I think, though, that some caffeine, as you mentioned, does have some health benefits in a measured amount. But like everything, like anything we do, too much of a good thing becomes harmful. Too much water can be harmful. Too much oxygen, we know that is harmful. So too much caffeine makes sense then. So if you're drinking 8 cups a day, you probably need to cut down. And I would say really try and aim for, 2, max 3 a day. And probably closer to 2. I'm just looking at I probably drink 3 some days. But yeah. But the thing that I also do, and this is a completely separate topic, but obviously keeping the majority of your caffeine before midday will help you sleep.
Sleep is so important, and sleep is restorative for all of these amazing cells in our muscles and our bones as well, and recovery from whatever we're doing.
You're absolutely right. It's a great segue. I didn't even realize I'd done one, but you're right, because part of this whole muscle development, bone health is that the rest phase, the bed, the sleeping phase,
is just as important. Yeah.
Yeah, good point.
We talked about in our first episode that we have a basal metabolic rate. Well, that's important. We're doing things even though we are just sitting there as well. So what you do in your activity phase is also helping your restorative phase. So
yeah, absolutely. We we have coined another little phrase because, lots of people don't like going to bed, particularly women who have been working and running around all day, and it's like your sacred time and it's the only time when nobody's...
Oh, I'm guilty of that.
Yeah.
Yeah.
So this is our little hack for that, is we have changed it's not called your bed. It's called your rejuvenation palace.
Oh, yes. Yeah.
And you go and imagine how much you would pay to go to a rejuvenation palace where you just lie back and all these things, your muscles are repaired, your bones are repaired, your memories are enhanced, your learning is, catapulted 10x. All of these incredible things happen. You'd pay a fortune. And all you have to do is go the hell to bed.
That's right. And that's why I often say that conversely, sleep deprivation is torture. So if we can just focus on that.
Yes. Sleep deprivation is the equivalent of, if anybody who's still working, if you're working in public hospitals, you will know that concept where they've told you have to do more work with less resources. That's basically what the brain says. Every time you deprive it of sleep, during that time, you're actually giving it more to do.
That's right. And it's compounding.
Indeed.
As you said, it's just compounding.
Excellent. Oh, I love this. So, summary for our beautiful listeners: to improve your bone health, obviously start early. The earlier you start, the better. But doing something is better than doing nothing. So start even with a tiny little jump. Just one little jump by the kitchen bench will start you on that impact for your bone strength. Strengthening your muscles is part of bone health, part of that whole musculoskeletal system. Obviously, food, alcohol is helpful and important, and HRT will be helpful. It will be absolutely helpful. And so if, you're at all on the fence thinking, I don't know if I really want to use it, well, look at all of the benefits in their entirety.
Absolutely. It's never too late to start either. I think that's, you haven't missed the boat. You might have low bone density. You might have the beginnings of sarcopenia, but you can do something about it now, and just consciously think about it in all your daily chores and your what you do, even in the car, there's things that you can do and be aware of.
Absolutely. I love this. Sunita, if people want to follow you or connect with you, where can they go?
Where can they go? Well, they can certainly go to our website at heromenopause.com.au. They can find us on Instagram at heromenopause. We're also on Facebook and LinkedIn. You're welcome to email us. Come and visit us at Hera. We'd love to meet you. And we love midlife medicine. We're passionate about preventative health and aging well, living life with quality, because that's what's life. Life is a very precious entity, and that's what life is about.
Yes. And making those glory years glorious.
Absolutely. I love that sentiment, Lucy.
Absolutely. Well, we will have all of the links to Sunita in the show notes. And so if you're driving and you're thinking, oh my God, I can't remember what she said, just go to the show notes at the end and click on the links and you'll be taken to her website. Dr. Sunita Chelva, thank you so much for joining us on the podcast. It has been an absolute pleasure and you have been a wealth of information.
Thank you, Lucy. The pleasure's been all mine, and I look forward to hearing some more podcasts from you.
Excellent. Thank you.
Thank you.
All right, listeners, I will be around next week and I'll chat with you then. Bye for now. The information shared on the Real Health and Weight Loss podcast, including show notes and links, provides general information only. It is not a substitute, nor is it intended to provide individualised medical advice, diagnosis, or treatment, nor can it be construed as such. Please consult your doctor for any medical concerns.